everybody hear me? I think people are still making their way back in, but I'm conscious of time. I'm sure people have got onward travel situations, so kind of get the session going. So feel free if you want to come nearer to the front. I think people are probably on their way to make a quick exit and get home now. Some tired heads in the room, no doubt. But we're at the last session, which is both really great for those of us that are really tired, not myself included, and also really sad because these conferences just fly by every single year, but it's been another really, really excellent one. And I'm really happy to be involved in the final session this year where we're going to turn our focus to health. That in itself doesn't really need any introduction, so helpfully most of the speakers, if not all of them, have kind of threaded health and the narratives and the conversations, the important conversations we need to be having around health through the last 2.5 days. Lord Mayor, back to Monday evening, opened talking not just about issues around stark disparities between life expectancies, you know, from one end of a road to another. 12 years, I think, was the number that he referenced, but also urged us to think about healthy life expectancy and to start thinking about those quality health years that we spend in our homes. Yesterday, it was really encouraging to hear from the Minister, Butler, who told us about the government's commitment to better connect the dots around health, and that's what we're going to hear about today from the speakers. This isn't a sort of a new area. We have swathes of examples of best practice, and we're going to hear about some of those today. With the government as well, kind of working hard to understand some of those challenges. Again, we had a session yesterday focusing on one of those, thinking about data, and a couple of our speakers are going to cover that off today. And how we work closely with health colleagues. And again, really encouraging to hear that the department are doing that and actively sort of engaging in that area. Sort of reminded as well, thinking back to Dara and Caroline yesterday on Peter's panel, thinking about the importance around delivery, both connecting the dots between health and fuel poverty that's dynamic, responsive, flexible, agile. We heard these words a lot. And how do we put that at the heart of delivery when we're thinking around improving health and tackling health inequalities, and that kind of importance of thinking and trusting in local expertise and knowledge. We've done our own polling in the last few weeks as well, so we know that those with health conditions and disabilities are going to be more likely or see themselves as expecting to be more likely to ration energy use, more likely to be in energy debt over the next couple of months. And what do we do, and what are we already doing? So like I said, there is lots and lots of best practice. Caroline pointed us towards why do we need to think about the health sector? Well, you know, it's that point of contact in our daily lives where we have some of those embedded, everyday, trusted connections with others, and we can have conversations around things that make us feel unwell or harder to manage our health conditions. But it's also thinking in terms of given the amount of money it costs the health system and the health service. It's currently and remains, you know, a huge missed opportunity to not be spending that money on getting out in front of the problem wherever and however we can. Thinking about some of those critical opportunities, and I'm sure some of the speakers will share some examples as well, thinking around things like health MOTs and other touch points that we have in healthcare settings to have conversations, again, as I mentioned, around our cold, miserable and sort of health damaging environments in our homes. This morning, turning to this morning, which already feels like days ago, time is going in a weird way now. We heard from Steve Rotherham this morning around how it's a public health priority. We heard from Rob at last year's conference about the same in Leicester and some of the fantastic work that they've done there to connect the dots on this. And we know that that is across the country, so looking forward to sort of questions, observations and thoughts from the room after we've heard from our speakers today. And then even thinking back just to the last panel with Colin and the speakers, we heard David from the University of Salford telling us that we aren't going to cover the cost of creating healthier homes through energy bill savings. And we're not going to inspire, or I think yesterday, lots of reference to winning hearts and minds or having conversations in terms and ways that people understand. So we need to look elsewhere. NEA are working on a programme that has taken steps in that, and I know some of the other speakers are going to also share examples of that. The order's slightly changed from what I expected, so I'm going to get this right from the paper in front of me. So first up today on the panel, we are going to hear from Jo Farrington-Douglas from Health Equals, and that's going to kind of zoom out a little bit and help us think about some of the building blocks around health and health inequalities. And then we're going to zoom in. We're going to hear from Fiona Miller, who's going to share some work that they've been doing around connecting the dots with data and working with the health sector in Staffordshire. We're then going to hear from Bill Purvis, NEA's very own, who's going to share the work of Warm Homes, Healthy Futures, which I think has been mentioned a few times, but we're going to get into the detail of that and hopefully share a bit more with you to start and continue conversations with those in the room. And then we're going to move over to Lucy and Rhiannon, who've kindly joined us from Cheshire and Merseyside ICB to share some of the work that the NHS are driving forward in this space as well. So without further ado, I'm going to hand over to Jo. Thank you.
Thanks, Danielle, and thanks for having me, and thanks for making health and health inequalities a theme of your conference. It sounds like it's come through throughout the week, and I'm just sorry that I haven't been here, not just to hear the other speeches, but also to experience a conference in a nightclub, which looks a lot more fun than a lot of the conferences that we're involved in. But also to thank you, the NEA, and for this whole community for focusing on health inequalities and fuel poverty. Fuel poverty is really one of the mechanisms that we would see that the situation that you live in translates into health outcomes, and cuts lives short. So we know, and you'll know a lot more about this than me, that there are 8 million people living in cold, damp, or dangerous homes that threaten their health, and that in two winters ago, that was linked to 5,000 early deaths just caused by cold homes. So the work you do is absolutely at the coalface of health inequalities. I'll just introduce myself. So I'm Jo Farrington-Douglas. I'm Senior Fellow at Health Equals, which is a campaign run by the Health Foundation. And I've got a little background about our campaign.
The Health Equals Coalition, made up of 27 organisations, has launched a visually thought-provoking campaign, Make Health Equal.
Across the UK, life is unequal.
We're here in Bradford, we're here in Birmingham, we're in the capital, in Newcastle, Manchester, Plymouth, Cardiff, with campaigning group Health Equals to let people know that their lives could be cut short by up to 16 years.
It makes me feel really sad.
Honestly, it's upsetting. Why should it be that way?
Well, it's because of things like income, housing, and air quality. For instance, take two babies like Louis and Lorcan. They have so much in common, but one big difference. This injustice is happening all over the UK. So we travelled to 50 towns and cities to photograph 50 portraits, which then became the face of a nationwide campaign. Then, we made it famous. On London's South Bank, we held Britain's youngest protest. Calling on the government to address this injustice.
I was actually quite shocked at that. I really thought it'd be higher. You know, she's not even 1 year old, and then you're talking about life expectancy just from where we live. It's not as long as other people, so it is quite an emotive subject, isn't it?
Growing up in a so-called deprived community where health problems reverberate all around your life, I think this campaign really brings it into focus at an important time in our history.
And like any protest, it got people talking. And signing our petition. Alongside our supporters and members, we took it all the way to the top. To place equal health firmly on the agenda for the next British government and generations to come.
That, I hope, gives you a flavour of the kind of campaigning that we're running in collaboration with organisations like National Energy Action. I'll be speaking about that in a moment. I've been asked just to give a bit of background. I'm a policy person and a researcher by background, so just to give a bit of context to the situation of health and health inequalities in the country and answer some of these questions. So the first question I'm going to be looking at is, where do you think the UK ranks internationally in terms of life expectancy? This was one of our stunts at party conferences year before last. Shockingly, UK has never been like at the top of the rankings for health, but you can see just before the pandemic UK is in the bottom third or bottom quarter of the OECD. In fact, we're there, you can't see it on here, but we're tucked between Chile and Costa Rica. And we were, in times gone by, we were more like 10th. And so what you can see here is the impact over the last decade of a slowing down in the increase of life expectancy. We were expecting life expectancy to continue to rise. It did all last century. But since 2010, that curve has flattened, and you see the impact of the pandemic as a catastrophic impact. But what if that line had continued to grow? What life have we lost? How far have our lives been cut short? If that trend before 2012 had continued, we would be seeing life expectancy of 3.8 years higher for men and 2.7 years higher for women. So that's the real impact of that lost decade of health. If we had those years back, we would be in that top 5 to 10 countries. What our campaign is really looking at is not just that lost health, but the lost health and how lives are cut short in different communities across the country, which is really the main focus of our campaign. And which places, then, do you think have the worst health in the UK? Well, our campaign has highlighted this 16-year gap between the lowest health and the highest health, small areas of the country. Our recent data from 2 weeks ago, produced by the Office of National Statistics at constituency level, actually identified Liverpool Riverside. So where we are sat now is the constituency with the shortest life expectancy in England. Glasgow, unfortunately, is even shorter. But even within areas like Liverpool, there's a wide variation, a wide gap. There's a 13-year gap between Edgehill and Calderstones just within that constituency. And those inequalities, sadly, are rising. It's not just inequalities in life expectancy, but also inequalities in sickness, in mortality. This is looking at levels of serious illness, and inequality begins early in childhood and really opens out in that during our working lives. And 15% of working age people have a major illness in the most deprived areas, and that's more than double the rate in the least deprived areas. And what's driving this inequality? What makes us healthy, essentially? And that's really the narrative that we want to communicate with our campaign. That when people think about their health, they think of it naturally, and also by the way that the media and the commercial interests present it at an individual level, so focus on behaviour and access to healthcare. But as you all know, it's the situation and the environment that you live in and the socioeconomic environment that you're born into that determines a lot of our health outcomes. So they're called academically the wider determinants of health, but to communicate this to the public, we're framing that as the building blocks of health. And you can look at the Health Foundation's guidance on how to talk about the building blocks of health and how to really reframe that conversation so that there's a real focus of awareness of the public and then focus on and pressure on politicians to try and address those building blocks of health. Our focus here is on housing as a building block of where we live, and that's one of our themes for our campaign this year. Again, if you look at the Health Foundation's evidence hub, we have all sorts of information about and statistics about the drivers of housing and health inequalities. We talk about there being 3 mechanisms by which inequalities in housing then lead to health inequalities, about having a decent quality, safe and secure home, and home affordability as being those 3 main housing building blocks. They don't operate separately. If you're facing one of those problems, housing problems, you're quite likely to be facing either 2 or 3 more. And as we see those problems build up, we can see the impact on health. That's the more housing problems you have, the worse it is for your health. So looking at good housing needs to be decent quality. But we know, as I said earlier on, the numbers living in non-decent homes, that's 3.5 million households in England living in non-decent homes. So that's homes that suffer from cold, damp, that are outdated or have those health hazards that lead to lives being cut short. You don't need me to tell you there are 6 million living in fuel poverty, but what's the impact of that on our health? Children growing up in homes that suffer from cold have double the rate of respiratory problems than those that don't. And 4.5 million older adults, who are most likely to be going into hospitals, have long-term conditions that are exacerbated by their housing. Added up, that leads to £1.25 billion costs to the NHS. That's just from the hospital admissions for those people who are suffering from poor quality housing. And that quality of housing isn't distributed equally across the population. So the more people on low incomes are more likely to live in non-decent homes, and that is graded across the population. And progress has sadly halted, with an increase in non-decent homes to nearly 4 million now in England. But it's not just about the quality of our homes, it's also about the security. We've seen evidence that people who live in insecure accommodation, insecure tenancies, actually, if their blood samples show they have higher rates of health-harming stress hormones. So we can see a direct link from their housing situation to their health outcomes. And just 20% of private renters have lived in their homes for 20% of private renters have lived in their homes for less than a year, compared with 6% of social renters and 2% of owner-occupiers. So that we have a strong focus on those private renters as being more at risk of being evicted from their homes. And we see this, again, we look back at trends of people's health. If they have had to move multiple times, particularly during their childhood, then you can see this has an impact on their home, on their health outcomes. And then finally, good housing also needs to be affordable. With the Renters Reform Bill, the Renters' Rights Bill, that's going to be making quite a difference to housing security for that group. There's also work going on to improve housing quality and spread those decent home standards. But this seems to be a relatively missing part of the government's policy agenda at the moment. Housing costs are unaffordable for more than a quarter of families on the lowest incomes. That's where more than a third of their income goes on housing. And again, younger adults, people from ethnic minority backgrounds, and those on lower incomes are more likely to experience those housing affordability problems. A research by the Joseph Rowntree Foundation found that 81% of low-income private rented households who are receiving LHA had gone without essentials, like food, heating and warm clothing, and 59% were in arrears with at least one household bill. So again, it's that mechanism, that link between your housing situation interacting with poverty that's creating poor health outcomes. And this isn't by chance, this isn't dictated by anything, this is through policy choices like the freezing of the local housing allowance. And at worst, you're seeing the catastrophic impact of this on people losing their homes altogether and ending up in temporary accommodation, with a doubling of the rate of temporary accommodation over the last decade. We've seen that significant uptick in the last housing survey, and 100,000 households now living in temporary accommodation. So that's a whistle-stop through kind of from the health to the health inequalities and the impact of housing. How can we achieve change? The work that NEA and this community is progressing, having the ministers coming to your conference and putting pressure on them to enact change at a national level is a key part of this. Health Equals is a coalition campaign. We want to bring together a chorus of voices from across sectors, so that's employment, housing, work, the environment, so we can talk about creating pressure on politicians for have a cross-government approach to reducing health inequalities, and also to take forward action on those specific building block areas. So I'm really grateful and really pleased now that National Energy Action has joined Health Equals as a supporter organisation. So we'll be able to work together with you to raise awareness of the impact of fuel poverty on health, and use your evidence and your case studies to take that to politicians, to take that to the public and to raise awareness. I also invite you to sign up to our campaign. You'll be able to hear updates from us and take part, but also to share back the evidence and the work that you're undertaking as well. So thanks again for the focus on health inequalities at your conference, and particular thanks to NEA for joining our campaign today. Thank you.
Stuart. Not sure if it's working. Yep. Next up, Fiona Miller from Beat the Cold. Thank you.
Sorry, just setting a stopwatch there because I do like to talk, so I don't want to run over. Thanks, Danielle, and thank you to Joe. I think that was a really sobering view of the bigger picture, why we do all of this work. And thank you to all of you. Thank you just for the warm welcome to the conference, but also to the world of fuel poverty. So I had quite a few conversations over the last few days where I shared that I've only been in the world of fuel poverty for just over 12 months. And Beat the Cold have been delivering affordable warmth work for just over 20 years. So I've got a lot of catching up to do. However, what I bring to the table is lived experience during childhood. So we can see here, going back to the 80s, I found this photograph over the weekend. That's my lovely nan, my brother and me. And I'm told that brown check couches were all the rage in the 80s. I think I'll leave the jewellery out on that one. And really, when we were young, we grew up with fuel poverty. We didn't call it fuel poverty back then. I think it was just called being skint. I think it is in some circles now as well. And we were really lucky when we were young. There was a lot of love in the household. You can see there, we've got some Christmas presents. I've been told that they were ordered out of the catalogue. And it was very hand to mouth. We just got by, as many families do now. There was an added layer of complexity in our household, as my brother had severe asthma, and so we were really reliant on energy to ensure he could use his nebulizer. And it was around this time that we were experiencing fuel poverty, where we saw the innovation of our neighbour, who wasn't much better off than ourselves, but used to actually run an extension cord from their house to ours through the windows. So not so much on the health and safety, but needs must. So we had all the lived experience of fuel poverty and what that brings. It was inability to wash school uniforms, keep the house warm, studying by candlelight, the stigma of the prepayment meters running out, and I'm told in the very early years it was shaking the back of the rented telly to fish a coin out for the gas meter. But what that brings alongside with me is the ability to see it through our service users' eyes firsthand, because I know what impact that had on our home, and I'm able to bring that along. So also with this aspect of childhood asthma, it was a really interesting opportunity about 12 months ago when the brilliant Louise Stockdale from University Hospitals brought an opportunity to Beat the Cold to look at a childhood asthma pilot. So for me, it was an absolute no-brainer. So today I'm going to share a little bit about the pilot with you, around the context of why, the setting. Many of you will know Stoke-on-Trent's an area of high geographical deprivation. And we're also going to look at the process so that hopefully you can take that away. And if you're not doing this kind of work already, there might be some inspiration for you to start opening those conversations. We'll look at the partners who are involved and the way that we communicated with patients. And we'll look at the impact, not just in numbers, but in real people's lives. And then I'll talk to you a little bit about the expansion plans. So many of you will have heard of our Keep Warm, Keep Well programme. It's one of our flagship pieces of health work, and it's been going since 2016. The innovative side of Keep Warm, Keep Well is that it's originally funded by solar panels. So on the hospital estate roofs, we have a number of panels which support with the energy costs of the hospital, and then the surpluses go into a solar excess fund that's managed by Staffordshire Community Energy and flooded down to Beat the Cold. Now, one of the core challenges with Keep Warm, Keep Well is that it's reliant on clinician referrals, and we all know, particularly with the pressures at the moment, that this is just another thing in a long line of list of things to do. And so we do get good referrals. We get referrals from the same sort of number of clinicians. You know what it's like, once you've done it once, they'll do it again because they know it has a good impact with their patients. But we really have struggled over the years, and so we've always had this idea that we need to be doing something different. We're also situated in the context of geographical deprivation and the brilliant headline of being the fuel poverty capital of England. So thank you to Anna and the team for that one. But in all seriousness, it is a real challenge. We've been hovering in the top 2, I believe, for years. And it was in 2022 when the new data was released that we went to the top of the charts. Not quite the one we'd want to be the top of, but I think that brings a real opportunity for change. and it's certainly high on the agenda with local authority. So when we put together the pilot, we looked at bringing together a truly integrated approach to care, and we worked very closely with the integrated care system to enable that. We used digital patient shared care records to enable this, and I'm sure that many of you in your trusts are also using shared care records in some sort of way, because we've got the beauty now that we've got this data, and so it's time to see what we do with it. The lovely thing about this campaign is that we're able to target, so we can target by fuel poverty quintiles, we can target by IMDs, we can target by conditions that are exacerbated by cold homes, and we use NICE guidelines to underpin that, NICE Guidance 6, as I'm sure many of you do in your fuel poverty work. So it was a long-winded process. This is literally just a nutshell, but you can imagine at first going to healthcare and saying, hey, can we have your patient data, please? Yes, thank you. Well, it's been a bit of a challenge, and it was the brilliant Louise Stockdale who did a high potential scheme placement. She works at UHNM. She was put on placement a day a week to North Staff's Combined Healthcare Trust. And Louise is the brainchild between the original Keep Warm, Keep Well scheme. So she's always innovating, always thinking sustainability. And she took this opportunity across the trust to gain that buy-in. Now, I hear that it was a little bit of a challenge in some areas, as you can imagine, but she's very tenacious and she was able to get that pushed through. At that point then, Louise developed with GraphNet a fuel poverty dashboard, which then enables us to really start drilling down to those fuel poverty quintiles. Once the scoping brief was developed, that was submitted then to the ICB. And it was just after I started at Beat the Cold, I think around 4 weeks after my start date. I was still a rabbit in the headlights, didn't know anything. There were so many acronyms. I mean, what is this sector all about? That Louise came to me with the opportunity, and the GraphNet team did a demonstration of the fuel poverty dashboard. Now, I don't know about you, I'm a real data geek, and so when I saw the capabilities of this dashboard, I've seen some data in my time, I've seen some CRM systems, but I'd never seen anything like this. I was blown away. So we were instantly on board. We then worked together to develop the patient communications and selected the final targeting, which was IMD 1 and 2, fuel poverty quintile 1 and 2, and childhood asthma. That had an extra layer of complexity because, of course, then we were targeting patient guardians, but we felt that that was going to be an area of real impact. We did a little celebration dance when we finally got the shared data sharing agreement signed, and then we were able to go live at the end of May last year. So we split that into 2 phases, which I'll tell you a little bit more about in a moment. And we are literally just wrapping the pilot up now. So we cut it off last week. We're now doing first insights and looking what learning we can take forward. So I'll give you a little bit of logo soup now. This is the One Health and Care record, which the Staffordshire and Stoke-on-Trent Integrated Care Board commissioned through GraphNet to develop. So One Health and Care is fed into by all of these partners, and that's across adult health and social care through local authority and health partners as well in primary and secondary care. The logos that you see on the right were formed together to bring together the organisations for the pilot. In terms of patient communications, we wanted to ensure we took an inclusive approach. So where we had mobile numbers on file, the practice were able to send a text message with a digital leaflet, the one that you see on screen, and where there was no mobile number, a printed letter and accompanying leaflet. So in phase 1, the practice, should I say, invited inbound contact to Beat the Cold. And it was at that point that we sat there and thought, what have we done? Because this phase was for 4 months and we had 4 incoming patients. So, of course, with any new pilot, you think, well, this was the greatest idea in the world, and we just weren't inundated as we expected we might be. Luckily, we'd got phase 2. Phase 2 was where it gets really interesting, and I genuinely believe this is where the true innovation comes in. So phase 2 then enabled the practice to share the full data set with Beat the Cold. That was already covered off in the data sharing agreement. And at that point, then Beat the Cold were able to make outbound calls to the patients, which was luckily a lot more successful. And then I could sleep at night again. So in terms of impacts, once we got hold of the data, we were able to have a 61% conversion, which we were thrilled to bits with. When we originally set the pilot up, we expected around 25%, so it was a real good indicator that we were working in the right space. And it's nothing that we don't already deliver as fuel poverty advice experts. So you'll see a range of the interventions on the screen there. What was different is that we tailored it to the health condition. So we made sure there was a lot of advice around damp, mold, ventilation. But again, nothing that our amazing advisors wouldn't already do. We were able to deliver around £13,000 of intervention or potential grant funding to the pilot, and we're talking really small numbers here, so successful interventions only 55, but enough to make a good pilot. But the most important thing is of those 55 patient guardians, 85 immediately self-reported an improvement in well-being from the intervention with Beat the Cold. So numbers are great. I think numbers enable us to build new schemes and to take things forward, but what we're really interested in is what does this do for patients' lives. So Matthew's story is a really sad one, and it's really interesting that in terms of the timing. So Matthew's patient guardian has worked with Beat the Cold 8 times over 6 months, and out of those 4 that contacted us in phase 1, Matthew's mum was one of them. So Matthew lives in an area of high deprivation. It's a local authority property, 3-bedroom semi-detached house, and he's got 5 siblings, so there's 7 people living in the home, his mum and 6 young people. There's a lot of challenge there in terms of affordability, and so there was often issues around fuel poverty and food shortages as well. When Matthew's mum contacted us, she was really concerned because Matthew's asthma had been exacerbated. He's 14 years old now, and early in 2024, he'd actually been admitted to intensive care. And it was during that time that Matthew's mum really didn't know where to turn, and luckily the amazing clinicians at University Hospital were able to get Matthew back on the road and get him home and well. But Matthew's mum was living in fear of this happening again. So again, our energy advisors delivered what we think of as our normal support, but what families think of as an absolute lifeline. So we're talking crisis intervention like food bank vouchers, fuel vouchers, water tariff support. We surveyed the property, we found damp and mould in Matthew's bedroom, so we immediately sought to make referrals to address that. And just really some advice around using TRVs, better use of heating and safe temperatures. And I'll put it in the words of Matthew's mum because I couldn't say it better myself. Matthew's mum said, "It was so frightening watching Matthew gasping for air. He couldn't speak and I thought he was going to die. I genuinely feared the worst." The text message came just at the right time, and as soon as I saw that we could get further help for Matthew's asthma, I was straight on the phone because I just kept panicking. I don't have much support around me, especially after losing family members. And it is just so good having someone there to listen and help. So I'll leave you with this. We are thrilled to bits to announce that our expansion with this pilot will fall under the Warm Homes Healthy Futures programme. And I won't go into any further details because I don't want to take the spotlight from Bill. Thank you.
One second. Hello, everybody. That's just fantastic. Beat the Cold. Been around a long time, but finally seem to be cracking the relationship between providing fuel poverty services in the health sector. Fantastic example of a very local delivery project as well. So, but I'm here today to actually talk about sort of a national project, which some of you will know about. It's the Warm Homes Healthy Futures programme. I'm giving this presentation on behalf of all of the National Energy Action teams that have contributed to the development and delivery of the programme. So I'm sort of the messenger. So what is the problem that the programme's trying to resolve? Well, we know that the vast majority of health professionals wouldn't really know where to refer a patient for support if they thought that patient's health was being affected by living in a cold, damp home. I mean, they might suggest that they get in touch with a local authority or something like that, but other than that, it's unlikely that they'd know where to turn for help. which isn't surprising because that's not their job. That is the job of the Warm Homes Healthy Futures programme and the partners. The programme is funded by the gas distribution network operators, and this invaluable support, you can see them all listed on the slide, enables the programme to cover England, Scotland and Wales. Its big objective is by March 26 to have helped 30,000 households with health conditions and disabilities to stay warm, safe and healthy at home. It's the only network of this size and scale to be connecting the dots between improving health and tackling fuel poverty. Now, to achieve this ambition, the programme is drawing on expertise across the health and housing sector and developing partnerships with organisations that are already successfully delivering health and housing services in their area. Let's take a little look at the areas where the programme's currently delivering services. Hey, if I go the right way, let's try that. So yes, the dots on the map show where the services are being delivered, and the colours show the different GDN areas. So to date, we're working at about 50 areas, stretching everywhere from Inverclyde in the north, right down to Devon in the south, and Denbighshire in the west, across to Kent in the east. These initial areas were selected because they were identified as having high levels of fuel poverty, deprivation, and health inequalities. But we also know that there are many more areas that could become part of the programme, and hopefully they will, where unfortunately similar conditions exist. And demand to join the programme at the moment shows no signs of slowing up, and the development team have had got a number of proposals in the pipeline. Let's just take a little look at who the programme's aimed at, how we find these people, and the way the service is being delivered. So the people that we're trying to find to help the client group effectively are people that are struggling with health condition or disability, made worse or difficult to manage by living in a cold, damp or poor quality home. So how are we finding these people? Well, there's two routes. Referrals can come directly from health and social care professionals, directly to National Energy Action, who will then deliver a full package of support. I'll explain in a minute what that support actually looks like. To date, we've got referrals coming in from health organisations such as adult social care teams in local authorities. We've got primary care teams using social prescribers, GP surgeries, COPD clinics, talking therapy services, community pharmacists and community mental health teams are all sending in referrals directly to National Energy Action for help. Interestingly, we've got some secondary care teams as well involved in the hospitals, respiratory care teams and cancer care teams. And I think it's great to see that some of the hospitals, I don't mean this in a bad way, but have the confidence and trust to send patients to National Energy Action for support, which is, I think, quite a barrier for sometimes for referrals coming in. Anyway, unfortunately, as you might expect, we've noticed quite a large percentage of clients are struggling with mental health and comorbidity issues, and that's the nature of this particular group of people that we're trying to identify. The second route is by working with established local delivery partners. And I think this is what makes the programme really different. So these partners already have a proven track record of developing referral networks with their local health and social care sector. And the services delivered by these partners uses their local intelligence, their local networks, and their local data and expertise, all of which adds massive value to the programme. So we can all learn from existing best practice and innovation. And I think what makes this particularly attractive for delivery partners is that they're fully funded through the GDN funding to deliver the services in their local area, and they can then work with National Energy Action to ensure that everyone gets a full package of support. And I think for some partners, this offer is acting as a catalyst for expansion of their existing services, and in others, it's helping the organisations to consolidate and complement their existing offer. I'm just going to give you a few of the delivery partners from across the country that are currently involved in the programme. So we've got a couple of councils, for example, and this is interesting, we've got a city council in Newcastle City Council, Unitary Authority, it's got health and housing in one organisation. Ashford Borough Council, just the Housing Authority, working with health partners in Kent County Council. We've got Energy Action Scotland, Warm Wales, Cumbria Action for Sustainability, I believe you're here somewhere, Beat the Cold, and you heard from Dominic yesterday from Energy Project Plus from Liverpool. So we've got a range of different delivery partners that we're working with. I think the range of health professionals involved across the social, primary and secondary care sectors just goes to show how the impact of living in fuel poverty reaches into so many different aspects of people's health and well-being. You can see from the cross-section of society here that there's a vast majority of people who are affected by the cold. So I'm just going to move on to the services that are available. And the first group of people I'm going to just talk about briefly are the householders and what they can receive. And, for me, almost every householder's situation is unique. And it certainly is to the householder who's ringing in looking for support. And therefore, the support always needs to be centred around the person and responsive to their individual needs. And this type of support often involves working in partnership with other organisations, other service providers, accessing local schemes to deliver a full package of support for those in need. Health providers call this co-production. It's like taking a collaborative approach to resolve a complex health issue. So these are the services that are available: bespoke energy advice and support. Interestingly, this gives us an insight into other housing issues as well. I'm sure that the teams that take all these calls can tell you about all this. And they have received over 1,000 households. They've managed to help over 1,000 households so far. Benefit and eligibility checks and income maximisation. Really popular. Often involves providing in-depth support with complex claims. And there's been almost £500,000 in estimated financial gains for clients so far. And then signposting people to other crisis support services, such as fuel vouchers or winter warmth packs. And interestingly, again, this is a GDN function of the programme, is that we can service boilers that may be malfunctioning or not working properly, and gas appliances to reduce the risk of carbon monoxide poisoning. If we come across boilers that aren't working properly and they get condemned, we have actually got access to funding for eligible householders to replace those boilers. So we're not going to leave anybody in the cold, which is good news. So, in addition, the programme offers community events, and these cover energy efficiency advice and carbon monoxide awareness training, and so far they've been delivered to over 1,000 people via groups such as asthma clinics, diabetes support groups, deaf and blind charities, Macmillan, or through mental health support groups such as Mind. Training is also available for professionals, and what I mean by that is like health professionals, and that also covers energy efficiency advice and carbon monoxide awareness. This is very popular, especially within the health sector, because strangely enough, the degree of unawareness of the impact of cold on people's health, believe it or not. So we had about 200 professionals who have received training so far, and about 1,000 carbon monoxide alarms and leaflets have been or are in the process of being sent out at the moment. So I hope you'd agree that this is a comprehensive, flexible and health-focused range of solutions. So I just want to share with you a short story about a client who has received these services and the impact that this had on his well-being. This is Stephen's story. So Stephen lives alone in socially rented accommodation. He unfortunately has terminal bone marrow cancer and neuropathy in both of his legs, which make moving around his home very difficult. He lives in an off-gas flat with no working heating system, and so he's currently using an expensive to run electric fire to keep his home warm. You all know what they cost. I was talking to somebody yesterday whose mum insists on using one for 24 hours and she's running up massive bills. Yeah, you know how expensive they are. Stephen told us that his council has plans to upgrade all of the flats in his building this year, which might be why they haven't got around to upgrading his heating yet. We'll give him the benefit of the doubt on that. So Stephen was advised that the situation needs to be investigated with his housing provider as soon as possible, especially because of the impact the cold has on his medical condition. In terms of assistance, Stephen received support from National Energy Action's Specialist Benefits team to apply for attendance allowance, which resulted in a financial gain of over £4,800 per year, which I would imagine was quite a life-changing amount for him. And this was awarded for an indefinite period, which reduced the need for Stephen to have to apply every year, and you'll see in a second why that's particularly valuable for him. Stephen also received £700 for the Warm Homes Prescription Project, and he was signed up to be put on his supplier's priority services register. And he received a winter warmth pack, and he was sent links for further support for his housing issues. So this is what Stephen had to say about the service that he received from the National Energy Action team. Thank you for your patience and help for chatting to me like I was a normal person. What I found is that a lot of people I used to see are no longer around. It's like they don't want to talk to me in case I pass on the cancer to them. I mean, how sad is that? And you can see why help with applying for his attendance allowance is probably critical. So I hope that Stephen's story gives you an idea of the kind of impact that the programme can have on someone's life, and especially non-monetary benefits, such as giving people hope and improving their resilience to deal with life's challenges in the future. And I kind of believe that this is the essence of the programme. Giving people confidence to face the world, ask questions, receive assistance. I think that's as important, really, as the money. And hopefully you remember at the beginning of the presentation that I said I was delivering this on behalf of all of the National Energy Action teams that have been involved in making and delivering this programme and making it come to life. And they're usually quite a humble bunch and don't blow their own trumpet, so I'm going to try and do that for them. So these are the teams that are and have been. I really hope I haven't missed anyone off. I don't think I have. But I'm also aware that I'm going to get shot by Anna if the last one doesn't show up at the bottom very well. The last one's the communications and campaigns team, who've obviously brought the whole of this event together as well. But you can see, can't you, from this, that this is a whole organisation programme involving all aspects. And you've heard and probably bumped into some of the people over the last day or two. And I, like you, I've been really impressed chatting to people with their enthusiasm for this project. So thank you very much. I'm going to actually leave with Danielle's details rather than mine. But thank you for listening, and I hope you've got a better understanding of what this programme's about. And we'll no doubt update you in the next opportunity, won't we? Yeah, thanks. Cheers.
Thanks, Bill, and sorry, Rhiannon. We'll now hear from Lucy and Rhiannon, who are going to share some details on work happening in Cheshire and Merseyside. Thank you.
Good morning. Thank you so much for inviting us here today. We're absolutely delighted to be here. So my name's Rhiannon Clarke, and I'm a Senior Programme Manager from Health Innovation North West Coast. And I'm here today with my colleague Lucy Malcolm, who's a Senior Transformation Manager from Cheshire and Merseyside ICB. And we're going to tell you about our work to tackle fuel poverty for respiratory patients in Cheshire and Merseyside. So why fuel poverty? Our fuel poverty project comes under the umbrella of the Innovations for Healthcare Inequalities programme INHIP. And that's a national programme from NHS England to tackle healthcare inequalities using the Core 20+5 approach. In 2022, Ofgem estimated that 450,000 households across Cheshire and Merseyside would be living in fuel poverty. Winter's challenging for all of those living in fuel poverty, but particularly so for those with respiratory conditions. These patients are at a greater risk of admission to hospital over winter and poorer health outcomes in general. So in Cheshire and Merseyside, it was decided to focus their INHIP project on respiratory patients and develop a fuel poverty dashboard using their Cypher data platform. That's Combined Intelligence for Public Health Action. It's a linked data platform which brings together health and social care data from across Cheshire and Merseyside. And it was originally established to support the region's COVID-19 response. But it now helps NHS and partner organisations across the ICS to understand and map population health data to support service design and improvement. We're really fortunate to have that data system, and this project has been all about putting that data into action. So similar to the story that you heard previously, we developed a fuel poverty dashboard within the CIPHER data system, which identifies the population cohorts at greatest risk of harm. And it brings together several data sets, including things like primary care level data, SUS data, local feeds from providers, ONS fuel poverty by lower layer super output areas, and Department of Levelling Up Housing and Communities energy efficiency data. We brought together representatives from across the ICS to determine which conditions that we were going to focus on and what the key interventions that would support the patients would be. And through that engagement, we decided to focus on patients with severe COPD and children with early signs of asthma. Local clinicians and care professionals spanning NHS, local authorities and the voluntary sector then took part in a series of place-based facilitated workshops, which gave the teams the opportunity to really interrogate and understand the local data and to work together to develop targeted actions to support people at greatest risk. We also supported them to develop pathways for delivery of these holistic reviews. We found that approach of workshops to bring those organisations together was really key to this work. Doing a clinical review and making sure the patient's medications have been optimised is really important. But having holistic reviews has been key to this work. There's no point in optimising the patient's medication and then sending them home to a cold, mouldy house. They're just not going to get any better. So we worked with several areas to develop local pathways. And we found that all of them share several key features. They all include a nominated person to access a database and create a list of patients. And then the clinical team undertake a medicines optimisation review and then refer to the other services. And they include things like occupational therapy, assessments, community mental health support, pulmonary rehabilitation, smoking cessation, social prescribing, and local authority schemes. In St Helens, that also included a £500 household support fund payment. Some of our local authorities were commissioned a charity called Energy Projects Plus, who I think you heard from yesterday, to deliver their fuel poverty work. And I think I'm just repeating what Dom will have said yesterday, but some of their offerings include things like helping people switch to lower energy tariffs, organising loft or cavity wall insulation, boiler repair or replacement, support to clear fuel debt, emergency fuel credit vouchers, and I think you know all of the rest. Here are some of the outcomes to date from this work. So, as you can see, we've helped over 650 patients to be put onto one of these fuel poverty pathways. Over 500 people have had their medicines optimised. We facilitated £362,000 worth of payments from the local authority household support fund. Over 500 referrals to local authority commissioned affordable warmth schemes, 325 to social prescribing teams, and over 270 families have been added to the priority services register with energy providers. Next, we just wanted to share a short clip of Diane Green. She's the lead community respiratory nurse from St Helens, and she's talking through some of the impacts that this work's had for her patients.
We've had patients say to us that we've transformed their lives. We've had a gentleman who had a wife and daughter who suffered from mental health, who has had new windows, damp course done in the house, mould has been treated, the walls have been replastered. They had a hole in one of the floors in their bedroom, so the daughter was actually sleeping with the mother and the husband was sleeping on the couch downstairs. That's now been rectified and the girl has her own room and the husband's now sleeping back upstairs. And since that intervention, he had had 3 previous hospital admissions and since the intervention has had none. Another patient who had mould in the house, their children refused to visit because of the mould on the walls and the state of the property. And they now visit regularly because all that work's been done. Patients are so grateful. You know, we're just at the tip of the iceberg. We've had patients say to us, I didn't believe it because this is too good to be true. It's just been a different approach. It's given the team more insight into the internal stresses that patients have. You know, as community nurses, we've always been very privileged in what we've been able to do, but this is definitely a step up from what we're told is proactive care. This truly is proactive care. This is holistic and looking at the causes of hospital admission And one of the causes is patients living in a cold, damp home with financial constraints and financial worries. So now, by giving them holistic care, the patients can keep their houses warm, they can buy healthy food, which increases their health status and improves their overall quality of life.
Hi everyone, I'm Lucy Malcolm. I'm a Programme Manager for NHS Cheshire and Merseyside, and I've been working closely with Rhiannon on this project. And I'm just going to conclude our presentation with a couple of key highlights of the lessons that we've learned through the work and a little bit about our plans for the future. So you've heard from Rhiannon and Diane there on the video about some of the amazing case studies and outcomes that we've seen as part of this work. And the amazing thing about this project is that we haven't needed lots of new money. We haven't needed to create any new services. The innovation has been in connecting the existing services and support and making them available to the identified groups in a targeted, accessible way. And another key outcome is the impact this has had on staff morale, as those involved are able to support people in a way that they haven't previously been able to. It's not just health support, it's holistic care for those that are in greatest need. Diane, who you heard from there, has told us that this is the most impactful project that she's worked on in her career, and others that are involved in delivering support have become so committed and passionate about it. It's been really good to see. And by learning and seeing the benefits of this approach, they're now starting to embed it into their everyday practice. We know that there's no point prescribing expensive medication and delivering other health support if we're then sending people home to a cold, damp house. Sarah Sibley, who's our respiratory lead in Cheshire and Merseyside, has talked to us about how she's always known that the wider determinants of health are important, and through this project, she now knows what is available and where she can signpost to. And so as standard now, she is starting to ask patients in her clinic, are they able to keep the house warm? Are they struggling to pay their bills? So what next for us? Anecdotally, we know that the work is having an impact on people's health and well-being and on service utilisation. And we have an evaluation underway, which is supported by the University of Liverpool, which is using a matched cohort of people and will hopefully evidence it's had that impact on services. The early findings from the evaluation do seem to be showing that those supported through this work have had fewer A&E attendances and fewer secondary care admissions than a similar matched cohort that haven't been supported. So we do need to do further work on this over the coming weeks and months to validate it, but this will really help us to roll out the project and extend it, which brings me on to our other priority, which is further spread and adoption of this work. Even without the evaluation, we know that this is a good approach and is making a difference to people's lives. So we want more places in Cheshire and Merseyside and elsewhere to use it. To help us do this, we've created a Fuel Poverty Toolkit, which is available on the website here on the slide. You'll find on the toolkit a number of resources that the existing projects that we've got have developed. There's case studies on there and a blueprint for how to develop a fuel poverty project. So I would encourage anyone who wants to know more to visit the website. So that's it from us. Hope it's been interesting and useful to hear about our work, and very happy to talk to anyone about it further. Thank you.
Thanks to speakers for joining. I'm mindful I'm sort of sat hiding behind the stand here, so I'll lean forward, otherwise I'm not going to see any hands up. And helpfully you've all sat on this side of the room, the majority of you. So yeah, thanks very much to all speakers there, giving sort of a real perspective of the different areas of work coming together. And I know that there are lots more of you in the room that I've spent time talking to over the last couple of days, both partners in Warm Homes, Healthy Futures, but also involved in some of the work in other spaces and areas. So really great to see those conversations happening, and I hope they continue. And we'll certainly be doing much more of that bringing together. So I know that we have a couple of sessions for those already involved in the programme in February, our referral partners in the health and social care sectors, our delivery partners working on the ground to bring together. But we also hope to have something in the summer to let you all come together in person, hopefully again, to kind of have this conversation around this space. So, do we have any questions in the room? and it is really difficult to see hands up. There's one on this side. I think some colleagues are having microphones. Sorry to make you run at the end of the day.
Hi, my name is Nick from Carbon Corp. Really incredible to hear your presentations and see the impact of collaboration partnership in this area. It's amazing. I come from a retrofit background. I was just interested in ventilation, whether installing ventilation has been considered as a measure in any of your projects, and any of the sort of thoughts around that or challenges around that, because it seems like a key part alongside fuel vouchers and other upgrades.
Thanks, Anika. I'm going to look to Fiona, Lucy and Rhiannon first, if that's okay. Try now.
Okay.
Can we have a microphone for Fiona, please?
Shall I just shout?
Yeah,
So there
thank
we go.
you.
That's better. No, it's a great question. We've certainly found in our pilot, so it's a part of our natural work that we do where eligibility is there. We do make those referrals through our Staffordshire Warmer Homes network. We did find with the pilot that actually a lot of those patients, because they are in those high IMDs, were already in social housing that had been covered off by the Social Decarbonisation Fund, but certainly we'll be looking to build more retrofit in as and when it's applicable and eligible. Thank you.
Yeah, I think again for our projects in Cheshire and Merseyside, some retrofit has been part of that, and we've worked closely with Energy Projects Plus, who are able to signpost into some of the available support there, and get that access to people where they're eligible for it.
And I think some of our pilot areas also linked in with the indoor air quality work that's going on in St Helens as well, because it was the same cohort, wasn't it? So there's been work about that as well.
Yeah, thanks. Phil, feel free.
Sorry, just a quick one. Anybody that knows about eco and any of the government grant schemes knows that the standard that they use, if you heat a house and you insulate it, you've got to ventilate it. So any schemes that are being installed through any of the government grants or energy company grants, etc., all include ventilation.
Yeah, I think the only thing I'd add to that from a Warm Homes Healthy Futures point of view, obviously Bill mentioned that community engagement, and my colleague Shelley, who I think is floating around the room, will be able to share more details of that. But a big part of that is not just around sort of CO safety from here's a CO alarm and here's how you use it, but thinking about the behaviours that we have in our home around ventilation and ventilation units and those conversations. Again, we're not just dealing with the bricks and the mortar, we're dealing with the people who live their lives in the household, and that's a really big part of what we do, as well as the services that are shared examples here too. I haven't seen other hands, but I think people are running around. Okay, we've got 3 on this side of the room. I think Laura's, Rob, you're third, I think.
Hi, I'm Sandy from 7Y Energy. So we run a very similar programme called Warmth on Prescription. I'm really interested in what you're doing with the University of Liverpool. We're looking to do something similar with West Wales as well, to try and get that data. There are lots of great projects like Fiona's, yours, and many others. How do we get to a point where NHS nationally recognise this, so it doesn't depend on great people both within communities and voluntary sector organisations and passionate people within the NHS, which is what seems to make these projects work, but loads of other people I know are trying to get their local NHS to get involved and do this kind of thing, but it's almost impossible. There's a sort of bureaucratic brick wall that it's impossible to smash through.
Feel free to jump in if you want. Yeah.
I think the beauty of amplifying this project, certainly for Beat the Cold through Warm Homes Healthy Futures, is the platform that brings on a national stage. We certainly see this work as a blueprint that could be taken forward for the NHS. I think amazing work that Cheshire and Merseyside are doing in-house, and then you've got the charity aspect as well, and I really do genuinely think that National Energy Action will be able to campaign to take this forward as best practice, and so...
I think for us, the first site that we've got set on is publishing this to get a good quality peer-reviewed paper out of it, and I think that will form a good evidence base for scaling and spreading this.
Good one. When I worked in adult care, delivering a Warm Homes Healthy Home type programme, the driver came for social care to act to help keep people warm. From the Care Act 2014, there's a couple of elements to that. One is that there's an obligation to try and prevent people falling into you know, an unhealthy sort of situation, as it were. And the other one is that you're supposed to look after people's well-being that are vulnerable. So there's a little bit of legislation in there that obligates social care to respond to the pressures that it's usually coming from the NHS down the line to social care. The NHS is saying, why aren't you helping get people out of beds and stopping people coming into hospital? So the pressure actually comes from secondary care, I think, down to social care, who have got a bit of an obligation to deal with it when they can. And that is probably almost how you get the NHS involved.
I think also from a policy perspective, you will have heard of the NHS Change programme at the moment that Wes Streeting is leading, and one of the shifts in his mantra you will have heard him go on about is that shift from treatment to prevention. A lot of what we hear politicians talking about is really sort of secondary prevention, screening programmes, vaccinations, all really important things, but it's sort of still within the kind of NHS services kind of environment, whereas these kind of services should be really what they're talking about getting to prevention upstream, exactly as that video said, tackling those building blocks of health. So if we can get this message into the NHS change consultation, wouldn't it be great for this to be part of that 10-year plan, so that it's kind of established on a national footing?
Yeah, and I think that's kind of it. I think there's also a collection here that you've got to, in spaces like this, all of us have that responsibility to be having the conversations over and over and over again, so it makes it impossible for those at the top to not be talking about it. So we saturate it, we share the evidence, we coordinate it, which is exactly NEA's focus with the Warm Homes Healthy Futures programme, is how do we bring that national coordination around this, how do we catalogue best practice, and how do we make it impossible to not be talking about this from the bottom up. And you know, you can't ignore it, I guess, is the hope with that. Things like talking in terms that are understood, so I mentioned publishing work, publications. We've done some stuff with the BMJ in the past to talk about the implications of policy for health in our homes, not just academic outputs, but policy, campaign. There's sort of no stone that we can leave unturned with this in that part of the conversation. So yeah, Sandy would be great to pick up, so, you know, join up, I guess, on some of those conversations. There was one in between Sandy and Rob. Could you put your hand up again on this side? I don't know. Yeah, there.
Hi, it's Christine Tate from Partnerships for Good. I was just wondering about connecting up with GPs. I know there has been a number of successful programmes, but I'm just thinking about my own GP. You can't get a GP appointment for weeks in advance, and they're really struggling at the moment, and I know they are with the number of patients that need to be seeing them. Some social prescribing programmes seem to have gone forward and seem to have been successful, but I still think there's a massive gap there, and I just wondered if the panel had any experience of working with GPs and how successful they've been.
You guys have got all the experience here directly.
Yeah, so I'll kick off if that's all right. So yeah, it has been difficult for us to engage primary care. Actually, a lot of our projects at the moment are led by secondary care services, but we have recently engaged a primary care network that is going to lead a field poverty project for us in a very similar way to the others in terms of accessing the dashboard and connecting into lots of other services. So we're hopeful that'll be a good example, and we'll be able to kind of build on our portfolio of the different models that you could use around this, because primary care obviously a really key partner.
Well, 10-minute appointments don't give GPs a lot of time to talk about anything other than what you've gone in for. The social prescribers, I think, are the people that actually have the time to talk to you about your issues. Is that what you're going to say? And the other one, I suppose, they don't go into people's homes like they used to. Yeah. So actually, I think going into people's homes is really the critical way to find out what's actually going on in someone's life. So they're not always well informed about people hide stuff from GPs, don't they? Yeah.
So in Staffordshire, our pilot was actually the data belongs to the primary care, so two practices that are combined together, Moorcroft and Moss Green. What we found is that there was, of course, some resistance in the beginning. It's another thing to do. It's added time pressure. but over time they're starting to buy into it more, and then once one goes, the others will follow. We're starting to get some traction around that, so it's not easy, but I think it's worth it, and we are finding, certainly in Stoke, we have an amazing network of primary care social prescribers, so that's also helping, and I absolutely agree that that's a really great route forwards because they do just have that little bit of extra time, but certainly I think a drum worth continuing to bang.
Just to add to kind of what you've both said, the primary care network that we're working with are going to make use of the social prescribers, I think, aren't they? And maybe some of the other ARRS roles like physician associates.
The only thing I think I'd add from like our, we've spent the last sort of 6 to 9 months talking to partners, health and social care partners and delivery partners, Bill and I and a few others at NEA, hours and hours and hours on the phone trying to understand some of the complexity around this. And it's kind of led us to this idea of connecting with the health and social care system, which is a bit academic and a bit vague, but essentially it doesn't necessarily have to be the person, the GP, so there are lots of different ways around, there are lots of different connections into that service. Or that system for people, and there's lots of spaces where people are having conversations and experiencing their health and well-being, not just in the GP surgery. So there's often ways to get through. I'm reminded of 2 really great projects that are nothing to do with ours actually, but I'm going to put Rosie on the spot. So Rosie from Citizens Advice Manchester a long time ago worked on a programme where they had telephones in the GP surgeries that connected directly to the Citizens Advice service. So a GP could simply say that phone's there. So wait times, sitting in the waiting room, and you could have that conversation immediately. Then there was another one up in the Outer Hebrides, which is why I'm quite keen to see one of the partners working with pharmacists at a community level, where very, very rural in the Outer Hebrides, and they had a pharmacy truck that drove around the households, and they connected with these types of services, and that idea of through the front door, understanding people's lives in their homes. So there is lots of innovation, even though we kind of think of some of this stuff as foundational or bread and butter. I'm conscious that we're at 1 o'clock, but Rob had his hand up, so I'd like to just make sure we cover one last question, unless anybody else has any burning questions, and I think we can steal 1 more minute.
I'll be very quick, because I don't want to keep people
Don't worry.
waiting for lunch. So yeah, I'm Rob Padden, Director of Public Health in Leicester and NEA trustee as well. And thank you for all the presentations, fantastic. And it really feels to me like we're making some progress in this after a long, long time, which is really, really encouraging. Health Equals, brilliant campaign, really inspiring. I'm going to join up. I haven't got around to it until now, but I will do. And Health Foundation, a fantastic organisation. I use their materials all the time. I'm just wondering what sort of traction you feel you're having with government on some of the arguments. And Fiona, I've worked in this field for decades now. You seem to have cracked the impossible in terms of the data sharing agreements and all that. I'm going to track you down personally, but also, are you able to share how you did that, the example of the sharing agreement itself, and how you overcame some of the obstacles? Not now, but maybe with a good practice guide or something like that. That would be absolutely invaluable. Thank you.
Excellent. Jay, do you want to take that first? What a government are they listening to you?
Well, so we've got to them. As have all the others who are working on this agenda. I'll give you the glass half full version first, which is we've got a government that's elected on a manifesto with a commitment for a fairer Britain, to halve the gap in healthy life expectancy between regions of the UK through tackling the wider determinants of health. So we couldn't have put it better ourselves. So that's what we were really pushing for there to be sort of a target and a commitment. And we have an ally particularly in Andrew Gwynn, the Public Health Minister, who's been working on this agenda for many years. I worked with him in Parliament in 2011, so he's really kind of gets it and is very passionate. He came to launch our Parliamentary Champions Network, and we've now got 70 MPs who signed up to our campaign and are asking questions. So I'm writing down as we're talking. Let's get some of those MPs in Liverpool who are part of our campaign, who are in the poorest health parts of the country, to write to Andrew to draw attention to these solutions, because that's what they want to see, is kind of hear, you're coming to us with the problems, but actually what are the solutions? So I think there's something we can put together as they're doing this NHS 10-year consultation. So that's the glass half full. There's obviously glass half empty. The economic situation is pretty dire. The political pendulum is kind of swinging, and the politicians' attention is moving to kind of being very much focusing just on those NHS access and acute access targets. So there is a risk that we lose sight of that prevention and lose sight of that need for a cross-government approach. So that's why we still need to be campaigning. But let's do that kind of intervention, get some PQs asked, and get a letter into Andrew to kind of put this forward as a kind of really practical solution.
Brilliant. Fiona, did you want to come?
Sure. So what I would probably say is it's not easy. There has to be a lot of tenacity, as you'd appreciate. And I think one of the key wins really is flipping the narrative. And so it's looking at the language that is going to attract buy-in. And that's not what drives Beat the Cold, it's what drives healthcare. So it's really looking at inundation, patient flow, and looking what we can do in the long term if we could reduce those frequent admissions. And I genuinely think that has been a big part of it, is to really demonstrate what we're trying to achieve in order to get those numbers down and bring greater benefit to healthcare and, of course, the wider determinants of health. But yeah, in a nutshell, really, lots of tenacity and banging the drum. Thank you.
I also wouldn't underestimate the value in having a Louise in Staffordshire and a Lucy and a Rhiannon, and find those people, because you guys are golden to us in this situation. We just need one or two that get what we're talking about in the NHS spaces to be able to help us set the right tone, speak in the right language, and get buy-in from the inside when we dial off the Teams call from our hard sell of the programme. But yeah, I'm going to end it there. The presentations, as with all of them, will be shared afterwards and available online, so you'll have access to those things. I think there was a few QR codes to follow up on. But if you could thank the panel in the usual way.
For those of you who have come to visit the National Energy Action stand, you will have seen that over the last 2 days there's been a hotly contested competition that's been taking place, and I've witnessed some lots of competitive nature of people in the room over the last 2 days. And it is, I would like to invite Darcy Collins from Smart DCC up to collect her prize, who set the mechanical programmers at a time of 1 minute and 50 seconds.
Okay, we're almost done, and I know you need to get off for trains, but give me 10 minutes, just 10 minutes at the end, because there's a bit that we really want to do. We've got some awards. I hope the people are here. We've got 4 awards, and then I've got a cheeky 5th, not award, but vote of thanks. So we like to do this, so we've got 4 awards. I'm going to call out your name. Once I've called out your name, would you mind coming up to the stage so we can take a picture and give you your prize, so you can milk the applause, recognition, and gratitude of your peers, and please do milk it. So the first one we call the Unsung Hero Award. We know there's many people in many organisations who don't get the recognition that they are due, and we're trying to make a little bit of compensation for that now. So the winner of this year's award is Emma Brooks. She's a Senior Partnership Manager at the National Energy Foundation. So Emma, would you, if you're around, could you come up and everyone give her a round of applause? What really sets Emma apart is her unwavering commitment to the residents that NEF serves. Let me read this. Her manager told us she is continually inspired by Emma's dedication, leadership and impact. She leads by example, fostering strong relationships with colleagues, partners and residents alike. Her innovative approach and tireless advocacy for those we serve make her an invaluable asset to our organisation and the community. She is a change maker, and she leaves a lasting legacy of warmth, health and happiness in every home that you touch. So congratulations and thank you. And, and thank you to Claire Durkin, Chair of NEA, who's giving out the awards, because I can't be trusted to do two things at the same time. More pictures? So the next one we call our Reaching Out Award. So we know, and we've talked about it a lot, that the disproportionate fuel poverty suffered by marginalised groups, and they can be very difficult to make sure your services reach them. So we have an award that's for somebody who makes really strong partnerships with organisations in their local areas in order to break down the barriers and reach out to people who are communities that are underserved. And the winner of the Reaching Out Award is Liv Gatford, Reach and Additional Support Manager at the Trust Alliance Group. Excellent, she's nearby. So she helps us as well directly, NEA and Energy Action Scotland develops mutually beneficial partnerships, relationships with lots of organisations, ourselves, Muslim Council of Britain, Leicester Public Health, One Wales, rural cultural organisations, and lots of others. It's so important that we have people who are able to make those connections, reach out to people, serve communities that need it most. Many congratulations, Liv. Perfect.
Thank you.
Right, the next one is going the extra mile. It's showing excellence in customer care, and we've seen a lot about the importance of doing that throughout the conference. The winner, and I think the winner's had to get a train, so we've got a colleague or former colleague to step in for it, but the winner, massively deserved, is Jen Smedley, who's project lead at Citizens Advice, DIS and Thetford, but I think it's been collected by a former colleague, Caroline Mackinson. There's Caroline, you've still got to come up and have the picture taken. Ever cheerful, sunny disposition, one of the things that clients notice. She's meticulous in her work. Her clients love her. Her organisation loves her. They don't know what they could do without her. So Jen, you're on the train going home, I think, but many, many thanks for all the work you do. And Caroline, thank you. And the last one, following on directly from the previous session, is positive impacts on health, kind of saving lives. Look, we know, and it's one of the key themes of conference has been that critical interaction between the two. We saw some great examples on the platform of people who are doing some really excellent work, and one person in particular, and that's Fiona Miller, who's the Chief Executive at Beat the Cold, who's our Saving Lives Award winner. I'll read out one thing in the citation because it's something I would love to be able to say about myself. Not only her source of enthusiasm and her resilience and her professionalism and her ability to communicate with people, the person who nominated Fiona said, "She is truly the most skilled and inspirational person that I have ever worked with." Wow. Congratulations, Fiona. I've got a cheeky one. And there's no award, so there's no point in him coming up to collect anything because it's not there. This is NEA conference in Liverpool. It's been a fantastic location for it. NEA's been working in Liverpool and the Merseyside for some time. And the heart of that work, but actually I was going to say that, but actually it's the heart of the organisation as well, is someone for whom this is his last NEA conference as a member of staff. And that's our own Jimmy Pugh. Don't clap yet. That's our own Jimmy Pugh. 12 years working with NEA as a project development coordinator. Calm and considered. He's the person I would want to support a loved one of mine who needed the work that NEA does. We know that he's loved because they tell us. We could do a ream of messages from clients that they love Jimmy and the community organisations, Jimmy, but we love Jimmy as well. He's a humble man. He's got nothing to be humble about. He should be proud of everything that he's done with his professionalism and his commitment. Has he skulked away? Has he hidden? He's here. Can we have a round of applause, please, for Jimmy at his last kind of conference? But you're not getting anything. So look, we're just going to wrap up. I'm going to say a couple of thanks. Then Claire is going to do a thanks, and I'll do a little kind of wrap up. Just the formal stuff first of all. Thank you all for coming in such numbers and being so engaged, making it, as always, a pleasure. I want to thank eVouchers for sponsoring the conference, for Octopus for sponsoring the bursary places, and I want to thank the NEA staff who've put this conference on and can take a little rest. We've chosen a great venue, and I think Claire, maybe just give a word of thanks to the organiser.
I will indeed, and first of all, thank you again, all of you. I looked up on AI, little speech on fuel poverty, I said, and it came up with a very good little speech, and I just thought, it doesn't touch the surface. Because the surface is you and people and getting together and doing. And oh my goodness, you've done it this week. And thank you very much indeed for coming. I hope it's going to be really useful for you in the year ahead. I want desperately, sorry, I'm Claire Durkin and I chair National Energy Action Board, which is a very great privilege of me. And I get to hug some great people. I do want, however, to thank the people that make it happen in National Energy Action. There's a team, and the team delivers. And it delivers so beautifully for all of you every year. So I know we all want to thank them. And it's Peter at the head of it is just inspirational, and he sees it all for a whole year, and he drives it forward. And Anna is the turbine hall, and God, does she create just dynamically. She makes all of this happen. But the whole of the team, from getting your food to getting your beds to getting everything, it's just superb. And the two eternal pillars of the annual conference, Nina and Brian, where would we be without your glamour and care? Thank you very much to all of you. And speed your journeys, travel safely.
Just before you go, I'm not going to sum up the conference, but I just want to, what we take kind of from it. So there's been lots of conversations about committed leadership, Steve Rotherham, from Yetta van Buller, from others. There's been a lot of talk about health and housing and the need for local delivery. So there's lots of information, a bit of information overload we'll think about over time. But what these conferences do, when this group of people comes together, it's as much about feeling an emotion as it is about information. So not what I've learned, but what I'm feeling. So one, I'm immensely proud of NEA, immensely proud of the people not only who put on the conference, but who do all the work to give us the content to talk about. I think I'm coming away being confident in this movement and its engagement with policymakers and deliverers. Optimistic to an extent. I'm a professional charity curmudgeon, glass half full with a bit of a crack down the side of it most of the time, but I think there is reason to be confident and optimistic about it, but I think impatient for this promise of policy frameworks to come about, impatient for standards to make sure that low-income households benefit from it, impatient for the outcomes, but also, and this is my last thought, impatient for the next time that we do this. And we're going to think, barring other evidence, we're going to try and do this at the start of the year for the next 3 years, so you can almost put a little bit of place in your diary for the NEA conference somewhere in England or Wales this time kind of next year. Thank you ever so much for coming. The food is available for those who haven't picked up. If I could ask NEA staff just to not join the queue until delegates have been able to get their food, because I know people have got trains to catch. So as Claire says, kind of travel well, bon voyage, and see you next time. Thank you.